Hello, friends. Greetings from India. Myself, Dr. Vishweshwaran, and I welcome you all for yet another web meet on interventional pulmonology as a part of IP Mentor web series. So, the theme for this web meet is peripheral pulmonary nodule. We all know that the field of peripheral pulmonary nodule using interventional pulmonology techniques is expanding day by day. And today we have two eminent speakers from across the world to share their insights on the advanced diagnostic aspects of interventional pulmonology in management of peripheral pulmonary nodule. So to have the first talk, we have with us a very good friend of mine, Dr. Abdul Hamid Al Reyes from USA. He's the medical director at the Advocate Lutheran, and he's uh, ex- expert in the field of interventional pulmonology, especially with respect to the peripheral pulmonary nodule. His field of interest include cone beam CT robotics in diagnosis of peripheral pulmonary nodule. So without wasting much of the time, we request Dr. A.B. Alreyes to present his talk on peripheral pulmonary nodule in 2026. How do I do it? Over to you, Dr. A.B.
Hi everyone, and thank you for the invitation to talk about peripheral pulmonary nodule in 2026, how I do it. The objective from this talk is to cover the understanding of the integration between robotic bronchoscopy and fixed cone beam CT that allow us to have more understanding of the process, how we do it, and unlocking the advance of capability of the synergy between the two technologies, and highlight some maneuvers and techniques that we use when we do those procedures. The main reason is that still, as we know, the lung cancer is the lead highest cancer in the whole world, and there is 2.2 million cases per year, and this rate is highest in developed countries, and still the lung cancer caused by smoking as the first cause. And from the data we have, we know that with the screening there was increase in the identification of double the number of what we used to know about lung nodules when we look at Nielsen and NLST studies. And still, out of all the cancers, the leading cause for death is, although the incidence is less than breast, colorectal, and prostate, but lung are the leading for the death per year. And combining, as I mentioned earlier, the robotic bronchoscopy with cone beam CT, and these technologies together allow us now to reach even farther nodules in the lung, even in the outer third of the lung, considering excuse me, the reach of the robotic bronchoscopy and augmented fluoroscopy images. And adding on that, also radial EBUS that help us. But still, we are needing to know more about lung nodules and know which one really we need to biopsy. Any lung nodule that increase in size, and especially above 8 millimeter, usually concern when the patient had history of smoking. On the also monitoring lung nodules, as this one increased from 3 to 4 millimeter to 6 millimeter over a range of 6 months. This increased the possibility of malignancy. Also, the shape of the nodules, as lobulated or speculated, increase the risk as well. And when we see cases that has these characteristics of smooth edge, but it could be a metastatic disease as well. When you see see it in the lower lobes with the smooth edge with multiple lung nodules. Lobulated, as I mentioned earlier, is one of the signs of risk of non-small lung cancer as well, and circulation as this example. The technology now allow us what we used to sample as 2 centimeters and above to be now up to 7 millimeter, which allow us to detect lung cancer earlier. And this is what the problem with the patient getting more screening, and they get a lung RADS category of 4A that's suggestive of 9 millimeter suspicious lung nodule, tissue pathology or sampling or PET scan recommended. Patient always under stress and worry, and if we waited as we used to do for 3 months, lung nodules can get bigger, and then we are losing the time for this patient. And from our knowledge about electromagnetic navigation study, we knew that the sensitivity for diagnosis of malignancy was around 70%. However, when they use only the cone beam on 5% of those cases, that tells you the importance of having some kind of 3D imaging that will allow us to improve, which is improved a lot when we consider using the shape sensing technology from point of robotic bronchoscopy combined with cone beam CT. In that study, the sensitivity went up to 91%. So our focus today will be talking about combining those two technologies and how we do it. It's a limited center where I work, but I'm going to share with you my experience with it. And really we focus on implementing the two technologies together by using A, B, C, D, and we'll go over each one of them. A is recommendation for anesthesia and preventing atelectasis. The bed height, very important. The clearance and centralization for C, and docking and diagnosis for D. So for anesthesia, we are aware of all the VISPA studies that showed with the when we are now using more cone beam, that Dr. Pritchett highlighted how the atelectasis would form if we don't implement a good ventilatory strategy. And preventing the atelectasis is very important. Dr. Casal and colleagues from MD Anderson showed how the atelectasis are forming more by 70% in the lower lobe comparing with 20% in the upper lobes. That what reflects the diagnostic lead higher in the upper lobes in general, and getting a fake or false positive signals from radial EBUS was the evidence of these misdiagnoses in the past. The bed height is very important for B, which is allow us to have the patient centralized and having at least 3 feet where we can have a good clearance when we do the spin. The clearance include that the patient height on the bed in lateral and AP, as you see here. And then docking and diagnosis, which is start with the procedure. So what we used to do, we used to navigate to the nodule and then perform a spin to confirm that we are in the right spot, and then do the biopsy. However, implementing the 3D imaging, having the spin with the support of augmented fluoroscopy, make the navigation has not only one tool to reach to the nodule, but also having both the navigation plan that built by the robotic bronchoscopy and the augmented fluoroscopy supporting the location of the nodule the same day of the procedure. After that, we confirm it with radial EBUS and perform the biopsy. This is a set of when we're doing the procedures, having both system implemented, driving to the nodule under fluoroscopy guidance, and with the augmented fluoroscopy supported by the planned CT. That allow us to reach out to nodules that not possible to be sampled by interventional radiology and very high risk adjacent to some kind of very vital organs such the heart or the aorta in this case. And in this case, patient has already previously a attempt for biopsy in another center, but ended having a cardiac issues before starting, referred for evaluation for using cone beam CT with robotic assisted bronchoscopy. The PET scan confirmed that the nodule is uptaking about SUV of 5, and when confirmed with angio to rule out any kind of aneurysm. Following that, as you see, the nodule sitting in the apical superior part of the left lower lobe, which is surrounded by the pleura from both sides, and also having a as you see here, the nodule really adjacent to the pleura in both areas. So building up the airway for the nodule was very important, and understanding that we are going from the lower lobe up all the way to reach that area. And after planning the airway, as before we start with a spin to confirm and see where is the nodule and the current day of the procedure after patient intubated and paralyzed. And this is the segmentation for the lung nodule, as you see, performed while we are confirming the adjacent to the aorta and also the location, and then building up a airway based on the blood vessel reaching next to that lung nodule, confirming ending in the lower superior segment of the left lower lobe. As you see here, using those markers support us to have a backup plan or airway during the procedure to know on the augmented fluoroscopy how it will look like to drive that path, which is supporting us not only from the planning platform from the navigation bronchoscopy, but also from the cone beam CT. After building up that, you can see now the nodule is located in the upper part. The advantage of using cone beam CT, we can build up also the blood vessel borders, which is the aorta in this case, to know where we are live on the case, so we prevent puncturing the aorta, which support us when we are trying to do the procedure and saving the patient from pneumothorax during the procedure, or puncturing a vital organ like the aorta. This is now the driving and navigating to the nodule using both navigation system, as you see in the lower part of the screen, and then driving through the airway that's recommended and following those tiny airway markers that we place with augmented fluoroscopy up to the nodule. When we reach the nodule, at that time we can see that the augmented aorta, nodule, and airway markers all augmented on the fluoroscopy. Then we place, for confirmation, we place the cryoprobe in position and we repeat a spin to confirm that we are tool in lesion. In some cases we use a second spin, especially when we are in delicate area that you see as in this example. So after spinning, we can now segment even the cryoprobe tip as well as the catheter, which is the scope, and that help us know where are we located on the airway when we do augmented fluoroscopy. And then we segment also the nodule to confirm that we are inside it. So as you see here, the nodule and the is in the correct position, and also we can segment now the nodule itself, which allow us to be seeing it on the augmented fluoroscopy. After segmenting both, we move to the next step, which is going back and confirm that we are inside by using radial EVAS, and you can see we are concentric and avoiding the lateral part of the medial part of the nodule, as you see it should be the aorta, which is right here. So we are more concentric now. After a little adjustment, at this point we perform the biopsy, and also we leave a fiducial for possible next steps treatment. This confirmed to be adenocarcinoma by pathology. This is a follow-up PET confirming that even the fiducial left in the right position. Another technique which we learned from using cone beam CT is the difference between inspiration and expiration, and the very importance of breath hold when you are performing a biopsy. Although you get a good radial EVAS with breath hold, you can see the difference between the two shadows of the scope while the patient's breathing and the original with the breath hold. And when we ask an anesthesiologist to breath hold, you can see it takes like 3 to 4 seconds to get back for the matching point between the two catheters, with a at least 3 to 6 millimeter difference in the location. So it's very important to have that breath hold while you're performing the biopsy during that time. Ground glass lesions, which is a very risky for patients, especially when they are having no clear guidelines if it's increasing, hard to measure if it's increasing in size or not. Cone beam allow us now to reach these long nodules, even if it's ground glass. Unfortunately, radial EBUS doesn't work in these situations, so at least driving to that location and placing the cryoprobe, as you see in this case, and confirming that we are inside the nodule, and that allow us to know the depth that we need to go in to sample, that help us getting diagnosis even for this case as ground glass next to the fissure, which reduce the risk of pneumothorax. And always we segment that nodule, as you see here, to make sure that we are inside the nodule. Also, this case came back as adenocarcinoma, as you see. So really there's no limitation for small lung nodules to sample, and we always now consider in high-risk patient getting biopsy for these patients, especially when they are confirmed growing with a significant smoking history, with even PET scan that give us a hint of increase of uptake, as you see in this case. Reaching out to these nodules in the past was very hard. But currently, with this combined technology, it is very easy to get to them. And as you see here, the size of the nodule rate between 7 to 8 millimeter, which confirmed and came back as adenocarcinoma as well. Another technique we use is the proning technique, especially to prevent atelectasis. And we learned it through one case that the patient presented with this CT scan that showed posterior lung nodule with emphysematous changes, that PET avid. The patient did not want to go through interventional radiology biopsy to reduce the risk of pneumothorax, so we underwent in 2 times, because the first time we performed in supine position, you can see how atelectasis formed in this patient even in the upper lobe. Compare when we repeat again after this first non-diagnostic biopsy done with the prone position. You can see how the atelectasis is forming on the posterior wall comparing to the anterior wall of the lungs when the patient in supine versus prone. For the same patient, same lesion. And I'm showing you here all the sagittal and then now coronal, and you can see how the lung nodule can be camouflaged and embedded in atelectasis. That's very hard to decide where it is only by counting ribs, but here you can still see the lung nodule standing out with the emphysematous bullies changes next to it. Same thing in axial cuts. You can see how the anteriorly here there is no atelectasis compared to the posterior and supine, wherever here when we did it in prone, you can see that it's formed in the anterior part, and the posteriorly the lung nodule was standing out without any atelectasis. That give us the accuracy to be inside the lung nodule, and you can see the confidence of being biopsying the lung nodule compared with the other one. The radial EVAS, you can see we got similar to the images we got from Dr. Casal study. One shows a huge hypoechoic area comparing with very accurate lung nodule shadow when we are in prone position. And that confirmed, reflected even in the pathology where it came back non-diagnostic when in supine compared with the prone. And that what make us think about when we should use the prone position. So those cases that after confirming that if it's posterior, medial, lower, BMI more than 32, and prolonged biopsy more than 40 minutes if it's expected, and if there is a difficulty to get the ventilation in the correct setting, that where we consider proning the patient. And the proning technique really decided based on the location of the lung nodule, and you can see those nodules in the medial basal part where it's hard even for interventional radiology to biopsy them. At the time we can go after them, especially using combined robotic planning to confirm where is the nodule is. And you can see here it's sitting in that triangle, which is the first area that the patient developed atelectasis when the patient in supine position, because this is the least area that can get ventilated even with hyperventilation. And you can see how much the area is narrowed and the nodule sitting in that area, and the importance of knowing the diagnosis will be very hard without implementing a direct view of that location. Combine both planning and proning in those cases helped a lot in identification of the nodule. This is, as you see, the CT scan. Before we prone the patient, we check for the tube to make sure it is above the cranium. When we confirm the tube above the cranium,
okay, can we put it back into this?
Put the patient in prone position and then figure out if we need to adjust the tube. We use a specific lap wrap, which is a setting where it wrap the patient when they are in prone position, doesn't allow them to move and have stability of the arms, and as well as using a specific prone pillow. Here is the prone when the team flip the patient. The anesthesiologist controlling the airway using that pillow to control it, and then we wrap the patient with that, and this is the final position where the neck is not hyperextended, the patient in prone holding in that position. After we put the patient on prone, as you see, we check the IV with the anesthesia, and then we use that lap wrap to hold the patient in one position and make sure that the lung nodule in the proper position in that location. Following that, we centralize. We need to remember that the nodule is in posterior position, so that we have to bring the bed down, as you see, to get the lung nodule in the area. And then we use a docking. Since the tube is shortened, we have to add some kind of extensions. It's called a gooseneck that help controlling the airway and helping extending the adapter of the robot, as you see it here, with two extension. This allow us to have the patency of the airway and ventilating the patient away from the arm of the robot. When we are in good position there, we confirm that all the connection connected with no chance of dislodging. Then we bring the arm of the robot and dock it to the adapter, maintaining a good angle, preventing any try to keep it perpendicular, as you see, as much as we can to facilitate the catheter or the scope to go inside with no issue. Very important to lubricate, especially with silicone spray, since we are going in a 90 degrees angle with the ET tube. To prevent that friction, we spray the catheter, the whole catheter, with silicone spray, and then introduce it into the angle where that sometimes needs some adjustment, and now the scope is ready and placed in the right. So from that point, patient centralized and connected, docked. So now we perform the spin to help identifying the nodule on the current position. The cone beam CT with the fixed Azorian allow us to pick the right position where the patient, if it's supine, where's the head to the head part of the bed. So we pick the part, that the head part toward the head of the patient but facing down, and that gives us the view that as if we are in the proper same as with not the same right and left and turn posterior the same. Now the spin performed, which is a 5-second spin with a breath hold. We use APL of 5 only. When in prone, we don't need to use too much of hyperventilation or high tidal volume. After the spin, we look for the nodule and we segment it, as you show in the earlier example. So we found the nodule. You can see how the atelectasis is formed anteriorly, no atelectasis posteriorly, and then we build up the airway markers to guide us toward the nodule. This is very helpful, as I mentioned earlier, allow us to have a backup airway augmented markers if the robotic has this planning some kind of divergence, which we see it in 20 to 30% of the cases in the lower lobes. When we get inside the airway, you will notice, because the patient in prone position, the airway will be upside down. So we always rotate 180 degrees to match anterior to posterior. After registration, we drive toward the lesion. So you can see we pass 1 segment, 2, 3, 4, 5 segments, 6, 7 segments, and 8 and 9, and we are really getting closer to the nodule. What you notice here, that the airways were all patent. There was no secretions, there was no collapsibility, even with the PEEP of 5 reaching the nodule. And that's the advantage we noticed with the prone position for that location of lung nodule. After reaching there, we segment the tool to confirm that we are inside the nodule. The same technique as we segment the scope as well as the needle in this example, confirming that we are inside the nodule not in AP, which is in coronal cut here, also on sagittal. And that's very important. And I'm highlighting here the position of the nodule where you can see it. We are concentric inside it, even in this delicate area. And you can see how the atelectasis did not form in that triangle, although we are next to the spine, as you see, which is helped a lot in preventing this atelectasis in the prone position. We confirm it also with it is another example that we drove to the lesion on the other side, the same location, and you can see again the patency of the airway without needing of putting high PEEP or high tidal volume. And when you reach there, sometimes we don't have to respin again, only using the radial EBOS was enough for us to confirm that we are in the right position. As you see here, the radial EBOS gave us a concentric confirmation inside the nodule. In this case, we don't need to do any kind of a respin. We confirm it and we biopsy. And using a needle or using a cryoprobe, either or, we use it to sample the nodule and getting the answer from there. So one of the challenges that came up usually when we do proning and the questions about it, the positioning time, centralizing the lesion, and the length of the robotic bronchoscopy, because we are going very far down in the lung that consume the length of the robotic length, that's usually 90 centimeter. Centralizing the lesion, very important, because you don't want to dock that robot before you are ready to centralize it. Otherwise you lose the spin effect and the nodule can be out of the spin window where you can see the lung without the lung nodule in that area. Positioning time is really a learning curve. When we started, it was taking around 30 minutes. Now it takes 5 to 10 minutes. And always, it's not every case. We used it only in 5% of our lung nodule sampling because we are very selective for those nodules that are located in high-risk patients in the medial lower basial. And as I mentioned, the positioning takes 5 to 10 minutes, highlighting the importance of the centralization is very important because the patient position in prone, not the nodule is not posterior anymore, it's more anterior. So that's why you need to bring the bed height down on lateral position, mainly to make sure that we are not outside of the zone of the spin. This is another example where we are going all the way down in the lung to sample. You can see that we consume most of the length of the bronchoscopy. But for more reading, please feel free to scan this QR code, which reflecting the 28 cases that we did with the prone precision reported in November 2025. We highlighted the protocol and the criteria for patient that we used in the prone position, and the average size for the non-nodule sample was 11 millimeter, and the total time of the procedure, including the staging EBOS, was 70 minutes, ranged from 41 to 108, and it was improving with the time that we are at the 28 cases, and the yield, which is the most important, was around 90%. But remember that we use combined augmented fluoroscopy, cone beam CT, and robotic bronchoscopy. So in summary, the robotic bronchoscopy and cone beam CT really give a lot of support for more accuracy during biopsies, and I would like to thank you for the invitation and thank the team I work with. I really appreciate the opportunity and looking to meet you in person in near future.
Thanks for an excellent talk by Dr. AB on interventional pulmonology practice in 2026 and peripheral pulmonary nodule. We heard a lot from his talk about all the advanced diagnostics that are being used in the Western subcontinent, and we saw how the robotics has revolutionized the diagnostic aspects of peripheral pulmonary nodule. Having said that, not all parts of the world have an access to the robotics, and still we are able to do good interventional pulmonology practice even without the robotics in this part of the world. So to share the insights on management of peripheral pulmonary nodule in a non-robotic setting, especially to focus on radial EBUS, to focus on the utility of C-arm with radial EBUS, and as well as to focus on the utility of the cone beam CT. We have another speaker from the western part of the India. He is Dr. Pawan Biraris, and he is currently working as a consultant at Tata Memorial Hospital. And he'll be sharing us insights on management of peripheral pulmonary nodule in an Indian scenario, which I feel will be pertaining to most of the developing as countries, as well as the eastern part of the world, where we don't have much of an access to the robot as of now. Over to you, Dr. Pawan.
Good evening, everyone. I thank Dr. Vishweshwaran, my friend, for choosing this important topic. India, we have a huge variety and huge load of the patients, including the malignancy as well as infection. However, our access to the technology is limited. We are making significant progress. However, in this talk, I will focus on practical aspects of utilizing the available resources for better patient care. So next 25 to 30 minutes, I will take you through Indian scenarios and how we sample the PPLs utilizing the radial EBUS and few other technologies. We'll concentrate more on the case illustrations to understand these scenarios better. And we'll discuss about the importance of multidisciplinary team. In India, we have a unique epidemiology. Unlike the Western population, there is a high burden of granulomatous diseases like tuberculosis, fungal infections, and other infections. We have increasing incidence of lung cancer, especially adenocarcinoma in non-smokers. We lack dedicated screening programs. However, institutional opportunistic screening is available for those who want to access. And we don't have India-specific guidelines. But what does this leads to? Unlikely the Western scenario, the pretest probability models of predicting the malignancy, the Western models may overestimate malignancy in India. And there is a high false positivity on PET because of the granulomatous disease like TB and sarcoidosis. So not all that lights up is malignant in India. And you have to consider infection masquerading the malignancy in most of situations. So let's talk about Indian scenario in PPL. Commonly, we get three kinds of patients in my clinical practice. So we get patients mostly who come with a follow-up scans which are done for their known cancers to see the progress of a disease and to see the resolution. We have incidentally detected lesion, patient who went for coronary artery, CT coronary angiogram, or sometimes they go for some cough evaluation and you start to have incidental detection of the lesion. And we have screen detected lesion, though this scenario is less in India. How to manage that, how to access this lesion? We have option of a CT guided transthoracic needle biopsy or a basic bronchoscopic intervention. Certain institutions have access to bronchoscopy, radial EBUS, and navigation. And very few institutions, we can count on fingers, who have access to augmented fluoroscopy or a CBCT. Can we do upfront surgical biopsy or resection? Yes, we can, but this option is never a first option because most of times it's infection mimicking the PPL. And the surgical biopsy is considered when your initial biopsy is negative or it is not feasible. So we rely mostly on the CT-guided biopsy, bronchoscopic intervention, and if not, then the last option as a direct surgical biopsy. We have vast variety of institutions from public to the private sector, and the institutional access to the technology is also variable. We have majority of institutes have access to CT-guided biopsy and bronchoscopy. Very few have CBCT and body vision, but most of them have access to EBUS, radial EBUS, with or without navigation bronchoscopy, especially in academic centers as well as the tertiary care private hospitals. So in this talk, I will focus mostly on the technical details rather than the theoretical aspects of bronchoscopy with radial EBUS, bronchial branch tracing, and navigation. When you talk about these two entities, CT-guided biopsy versus conventional bronchoscopy, and look at the CT-guided transthoracic needle biopsy, the sensitivity is almost 80 to 92%, 100% in some centers with intervention radiology. However, it comes with certain risk of pneumothorax, very high, between 15 to 40%. And this increases with number of passes being done into the lesion. The distance from the pleura, the size of lesion equally influences the rate of pneumothorax. There is risk of hemorrhage as well, up to 5%. And recently it has been talked about the risk of pleural recurrence after CT-guided biopsy. So it's a very good option, but not suitable in all the cases, especially when you have a lot of emphysema, bullae, when the lesion is close to the blood vessels and sometimes subsolid lesions, it is difficult to access. We are not able to perform the lavage during the CT-guided biopsy, which is possible with conventional bronchoscopy. So let's come to our conventional bronchoscopy. It has sensitivity up to 30 to 65% to give you diagnosis only with conventional bronchoscopy I'm talking about. And yield depends on the location of the lesion, whether you have positive bronchus sign, a bronchus leading to the lesion available or not. Bronchoscopy essentially becomes a blind procedure for peripheral lesion because it can reach up to the 4th or 5th generation bronchus if you utilize the thin scopes. When you couple with fluoroscopy is limited by its two-dimensional vision. So sometimes there is a risk of false localization. It appears that you are inside the lesion, but you are not. So these are the limitations of conventional bronchoscopy. How we can overcome this? We can couple it with radial EBUS. We can use ultra-thin scopes. You can use virtual navigation bronchoscopy, CBCT, or augmented fluoroscopy, which will increase your diagnostic yield to match to the CT-guided biopsy yield. How to select optimum diagnostic approach? When you have CT-guided or multiple bronchoscopic intervention, which procedure should be done for which patient? So we look at certain parameter. The parameter depends on the lesion specific, whether you have a positive bronchus sign, whether it is a non-vascular lesion. If the lesion is located in medial two-third with larger, more than 2 centimeter size upper lobe location than lower lobe, in that situation, we can consider one entity over the other. If you have lesion located lateral one-third, but you have access to the other technologies for tool in lesion confirmation. Patient-specific parameters like patient is medically fit. You can secure and protected airway when there is a hypoxia or if there is a risk of bleeding. Can you secure an airway? What are the lung parenchymal conditions? You have emphysema, cyst, or bullae present along with the lung lesion. Whether there is a coexisting lymphadenopathy, what is the pretest probability of infection in a particular given patient, and a scale of operator. So all these parameters, when you do a checklist, if they are yes, you can consider a bronchoscopic intervention. If they are not, then you can consider a CT-guided biopsy. And remember that these two techniques most of times become complementary rather than competitive. How to decide about which nodules should be sampled, and it is important to have a multidisciplinary team. Most of times, pulmonologist becomes the first point of contact. However, in a MDT, you should have a thoracic surgeon, a radiologist, a radiation oncologist, pathologist, or sometimes anesthetist, depending on the complexity of scenario. And if you don't have MDTs in an India-specific situation, you can utilize services from National Cancer Grid, NCG, or NCG Vishwam, which are the initiatives of Tata Memorial Hospital, which is a virtual MDT conducted for the hospitals who are already member of NCG group. So let's come to the detailed talk of how to sample these PPLs in India, the technical details. And in this, we will go through what is radial EBUS, what are PPLs, and this is for the beginners. How to understand you have to understand the instrument, how to choose a scope, and in a case-based discussion, we will go through step-by-step approach of a radial EBUS, bronchial branch tracing, and navigation. So what is radial EBUS? Radial EBUS is a diagnostic modality. It utilizes a miniature ultrasonic probe like this, which is introduced to the working channel of a bronchoscope, and it provides sonographic images of a peribronchial tissue. In PPL, there is no precise definition for PPL, but the criteria used are like if the lesion is located in a lateral 1/3 within 3 centimeters of a pleura, and those that cannot be visualized by a routine flexible bronchoscopy are considered as peripheral lesions. And if I divide the thorax in medial 1/3, middle, and then a lateral 1/3, the lesions located on this third image are mostly the PPLs. What is more important is having a bronchus leading into the lesion. That is called as positive bronchus sign, like this, where you have the bronchus leading to the lesion, or the lesion is completely encircling the bronchus. In this situation, your diagnostic yield of bronchoscopic modalities goes up. So these are the CT scans you usually get with a positive bronchus sign, or you have a subpleural lesion without the bronchus sign. And this is your aim of taking your bronchoscope and your tools inside the lesion. The journey through this goes through adequate preparation of your radial EBUS, your guide sheets, selection of scopes, sampling tools, whether you're going to use forceps, whether you're going to use cryo. You have to plan all these situations before starting the procedure. You have to understand the path well, and you can utilize your available gray matter by using a bronchial branch tracing technique, or you can rely on one of the navigation technologies which will guide you to reach to the lesion. And under fluoroscopy guidance, even if you think you are reached to the lesion, but tool in lesion confirmation with techniques like body vision or augmented fluoroscopy, CBCT will help you to sample the appropriate location of the lesion to improve your diagnostic yield. Robotic bronchoscopy is not available in India, but it has all the platforms clubbed together to give you best diagnostic yield, even if the lesion is located most peripheral subpleural. So let's start with understanding this instrument. Most of you might be familiar with the linear EBUS. Similarly, we have a radial EBUS, and majority of centers are using it now. So what is radial EBUS? It's a rotating mechanical transducer, rotates 360-degree along on a long axis of the scope rather than a fixed transducer of a linear probe. It utilizes frequency up to 20 megahertz with a good tissue penetration up to 3 centimeters and excellent imaging of a peribronchial layers. But it lacks the real-time TBNA. What is possible in linear EBUS, the real-time biopsies is not possible in radial EBUS. You have to take out your radial probe and put your accessories through the working channel. And it doesn't give you a Doppler signal to identify blood vessels, which is possible with your linear probes. We have two important companies providing this instrument, Fujifilm and Olympus. In Fujifilm, we have a probe of 1.8 millimeter diameter. It's a standalone system where the processor leads to integration of sound waves into conversion to these images. And it's a standalone system from the EBUS. While in Olympus, we have integrated EBUS as well as the radial EBUS system. We have two different probes from Olympus, 1.4 and 1.7 millimeter size. And from Fujifilm, we have 1.8 millimeter probe. So when we once we understand the probe, let's come to the selection of bronchoscope, which is going to be your driving path towards the lesion. So the selection of bronchoscope depends on where is the lesion located, central versus peripheral. Are you going to use a guide sheath, or we are going to sample without a guide sheath, and what accessories you are going to use, what is the size of accessory? Accordingly, you have to select the working channel of a bronchoscope. And we have a wide array of scopes available. Majority of times for central lesion, we use a larger size scope, while for the mid to the peripheral portion, we can use the thin and ultra thin scope. So what do you mean by ultra thin scope? It's a scope with 3 millimeter 3 millimeter diameter with working channel of around 1.7 millimeter is the ultra thin scope. While in a thin scope we have working channel of 2 millimeter and a scope diameter of around 4.1. And this is how with a larger scope you can utilize only to the central or a mid portion, but with an ultra thin scope you can go almost up to periphery. It is when the working channel is limited, accordingly you have to use a guide sheath. A guide sheath can be used only with the thin scope. What ultra thin scope, we can't use the guide sheath. And the forceps commonly used are around 1.5 millimeter biopsy forceps. With the thin scope, you can use a little larger forceps of up to 1.8 millimeter size to have adequate sampling. There are different generation of the bronchi when we go from the segmental to the subsegmental level, and these scopes have different reach to these lesions. Most of times your conventional scope reaches to the first and second generation bronchus. The thin scope goes up to fourth or even fifth generation bronchus depending on the patient's height and the age. And beyond that, one or two more generations, ultra thin scope can take you towards the distal lesion. This is the aim which you target with the ultra thin or thin scope. And the other accessory is the guide sheath. We have currently a guide sheath, I think case 03, which has certain stoppers to help you to gauge the length of your guide sheath as well as the length of your radial probe. And there are different accessories available with that to sample these lesions like cytology brush, biopsy forceps, and bronchoflex, periview flex needle, which is an aspiration needle. The guiding device is not available in the sheaths nowadays, but if you have older generation radial sheath, you can utilize the guide sheath. And if you want to sample the eccentric lesions or sometimes get good chunk of a lesion, you can utilize the flexible probes, cryoprobes. Earlier we had reusable probes, now we have disposable probes. And for the peripheral lesion, most of times the mini probe 1.1 millimeter size probe is used, or you can utilize a 1.7 millimeter probe if the tissue is not adequate. But commonly used is the mini probe, which is 1.1 millimeter. So we understood the scope, we understood the probe, we understood the accessories. Now let's come to the radial EBS image. Once you start screening the lesion, you may see a normal lung, which is described as a snowstorm standard appearance. And when you reach to the lesion, if you look at this image, on the central portion, we have a central black circle, which is a probe position. This P demarcates a peribronchial pulmonary mass. These arrows represent a solid tissue, solid lesion to the air interface of the lung. And then surrounding lung is seen as a snowstorm. The lesions can be homogeneous or heterogeneous depending on the air and the solid tissue or a fluid content in the lesion. Once the probe is inside the lesion, you get a concentric image, and this is the aim to have a concentric image in most of the situations, most of the lesions, so that you can have adequate sampling. But every time it's not true. Sometimes you probe just reaches to the edge or the side of a lesion, and this generates an eccentric image. While if you're completely in a different segment than the subsegment of the lesion, then you will get something called as adjacent image when the probe is not placed, and you have to go back to the segment of interest to generate eccentric or a concentric image. When you talk about solid lesions, it has air as well as fluid and some solid content of a tissue. So depending on the content of the air, if there is a large amount of air is present in bronchus or a lung tissue, then you'll get these arcs, larger lines, more than 2 millimeter. When you have a little content, it leads to hyperechoic short lines up to 1 to 2 millimeters depicted with the red arrow. And then if there are only very little content of the air, you lead to having these hyperechoic dots. They are equally important to understand gross lesion appearance to decide whether it is possible to have whether it is a pneumonia or a malignancy, and there has been some classification related to that. But we are not able to replicate the same classification especially with the endemic countries where the infection like tuberculosis or fungal infections dominate in our situation. How to identify blood vessel, as we don't have a dedicated Doppler here. So if you can see the blood vessels being sometimes pulsatile, or you can see a round anechoic area continuously. When you screen lesion from distal to the proximal, you may be able to see continuous round anechoic area, which is possible blood vessel. If these similar areas are present in a localized section of the lesion, then most of times they are necrosis, not the blood vessels. However, a careful reading of a CT scan can help you to understand the relationship of a blood vessel to the lesion. Not all lesions are solid, and some lesions are ground glass opacity. So this is a normal lungs. We have this normal snowstone appearance of a lung, but when there is increased acoustic enhancement, whitish acoustic shadow with subtle noticeable increase in intensity, it is called as blizzard sign. And when you have air densities or a hyperechoic dots, linear arcs or vessels inside these blizzard sign, this is called as mixed blizzard, and they are indicator of presence of malignancies like adenocarcinoma. So now we know the scope, we know the probe, we know the image identification. Let's talk about how we can reach to the lesion and tracing the path. And for this, you have to study this lesion in all the axes possible, including the axial, coronal, and sagittal CT sections. Understand the relationship of this lesion with the bronchus, with the blood vessel, so that it can guide you better to the desired segment and save a lot of time. There is a dedicated technique by Professor Nariaki Karumoto. The art of Karumoto of bronchial branch tracing is a beautiful and excellent technique. When you don't have access to the technologies, this is a savior, and believe me, most of times it is sufficient, especially when you are dealing with central or a peripheral lesion. So this is the way we draw the bronchial segments. Itself is a talk for 30 minutes, but in interest of time, I will discuss this in case-based illustrations. So how the radial EBUS procedure is performed, the bronchoscope, your working channel bronchoscope of around thin or ultra-thin scope can be chosen for a particular lesion. With the help of bronchoscope, you take yours to a desired segment and put a radial EBUS through the working channel and activate it. If you are not into the segment of interest, you may get this kind of shadows, which is called as snowstorm appearance. Hence, in that situation, it's better to study the scan and identify the segment before, and that's where the bronchial branch tracing helps. You go to the desired segment, put your guide sheath in that, and once the radial probe goes in, you activate the probe, it rotates, screen the lesion from distal to the proximal side. And once you are exactly in just proximal or mid portion of the lesion, you can pass your brushes, your forceps, take adequate biopsy. You can use your cryoprobe also. When you use the cryoprobe, most of times we don't use the sheath. Under fluoroscopy guidance, you can sample these lesions. We sample almost 5 to 8 biopsies, depending on the microbiological, the histopathological investigations. And because of the molecular marker requirement, we need more and more tissue. After adequate hemostasis, you inspect the airway and come out. Most of times we use the protected airway and total intravenous anesthesia when you are sampling multiple lymph nodes as well as the lesions together. So let me take you through these case illustrations, and we are going to discuss around 5 to 7 cases. The first case is a common scenario of a Western country's skin detected nodule. When you have a screening program in place, in a smokers, and this is a case of a 50-year male cigarette smoker with 30-pack-year history, comes in a lung cancer screening clinic, and his second scan shows around a 14 millimeter right lower lobe space occupying lesion, SPN, space occupying solitary pulmonary nodule. And you can see that this is a very soft tissue density, no calcification, and it has the some irregular margins. No mediastinal lymph nodes in this case. So we are dealing with SPN, no mediastinal lymph nodes, non-calcified lesion with spiculated margins. A PET CT, as it is more than 8 millimeter nodule, a PET CT has been done, and the PET is negative in this situation. But because the patients are high risk smoking status, we considered for a biopsy. Now it's a peripheral located lesion, easily targetable by a radiologist or intervention radiologist for CT guided biopsy. So the histopathology, this is a CT guided biopsy done, and we have through and through into the lesion, multiple cores have been taken. And this turns out to be a focus of a typical glandular proliferation with lipidic pattern consistent with adenocarcinomas. And these kind of situations are usually dealt with surgical resection in a solitary lesion. Our next case is not everything is a screen detected, and sometimes you do a scan for some other reason, and you tend to have nodules detected. So it's a case of elderly 78 years male who's has multiple comorbidities like diabetes, hypertension, and ischemic heart disease, has undergone a coronary angioplasty, and he presented with gastrointestinal stoma tumor with the stomach and the multiple location lesion, including the iliac fossa. This patient was treated with neoadjuvant imatinib, which is a standard line of treatment. and gets a good response and undergoes a surgical resection with resection of the mass lesion in the iliac fossa. Rest of lesions subsided with treatment. And this patient was subsequently maintained on imatinib and remained disease-free. So this was the scan during his treatment, where we got a consolidation in the right upper lobe lesion. We have pleural effusions, and subsequent scans shows resolution. However, because this patient had a good response, this patient was kept under radiological follow-up. And after almost 4 years down, you see there is a lesion appearing in the right upper lobe, very ill-defined. There are no PET avidity. There are no specific large mediastinal lymph nodes with PET avidity. So this is a scan of 2021, and he had undergone yearly scan. In 2024, he was referred with increasing lesion on the right upper lobe. You can see some mediastinal lymph node here at the 4R location, subinternal break, necrotic density in a contrast scan. So let me show you the scan. This is the lung window axial cut, and we have a lesion located in the right upper lobe posterior segment RB2, peribronchial, and there is one of the segments are reaching to the lesion. We have some mediastinal lymph node, especially at the 4R and station 7. So we went ahead with the bronchoscopy route, and this is the quality of video is because it's recorded with mobile phones, but I can show you we are reaching into the right upper lobe posterior segment, and this is we get beautiful image of a radial EBUS, and we can see a heterogeneous density lesion here around the bronchus. So this lesion has been biopsied. We have done a thorough lavage in that area. Both the biopsy and cytology shows adenocarcinoma positive for TTF1, turns out to be a primary pulmonary origin. The mediastinal lymph node was also sampled, and this lymph node, all the lymph nodes were negative except the 4R, which showed some area of necrosis, and it turns out to be MTP detected low on a gene expert. Rifampicin resistance not detected. This patient was started on anti-TB treatment. After 2 to 3 weeks of tolerance of this ATT, this patient was subjected to chemotherapy followed by radiation treatment, and for his GIST, imatinib was continued. So we had a GIST, we had a lung cancer, we had tuberculosis, and that is what a complex clinical scenario. And I'll show you a couple of cases how we encounter multiple pathologies in a single patients in Indian situation, especially when you work in a high volume center. So we do bronchial branch tracing, and sometimes we come across, we actually reach to the lesion. And this, in this case of a 54-year male who has been again a smoker, who had hepatitis B positive, who had COPD treated with inhalers. His patient was case of a hepatocellular carcinoma treated with radiation therapy and the lenvatinib afterwards. His blood investigations were normal. On the CT scan actual image, you can see multiple nodules in the right upper lobe, tree in bed opacity. There are some solid, well-defined nodules in the upper lobe as well as the lower lobe. Small and very intermediate, indeterminate to characterize, to call it as malignancy versus infection, but the upper lobe lesions are definitely appear infective. So a thorough lavage was done in this patient in right upper lobe as well as lower lobe, and it grows Aspergillus species. In immunocompromised host, you tend to have Aspergillus, fungal, bacteria, or a tubercular infection very frequently when they are on chemotherapy or immunotherapy. So this patient was treated with antifungal treatment. His workup for bacterial and tuberculosis was negative. Cytology was negative for malignancy as well. And this patient was screened after 3 months. If you see the lesion, which was earlier, right lower lobe lesion was a smaller size, which has increased with some effusion. The effusion was very mild. It was tapped. It was exudative. And then the subsequent scan done a couple of weeks down showed a resolution in the upper lobe lesion, very good resolution in the upper lobe lesion. But if you go down, we had a posterior basal segment or a lateral basal, posterior basal segment or lateral basal reaching into the lesion. And you can see a increase in the size of a lesion compared to earlier. So we decided to go for, this patient was referred for a bronchoscopic intervention to us. There is a bronchus leading to it. So let me show you how the bronchial branching tracing is done. So for the lower lobes, we flip the image. So we are at I am showing you this right lower lobe, and you can see this middle lobe taking off. Lower lobe is there. There is a superior segmental bronchus. And then we have the basal segmental bronchus dividing. We have It's usually meant, medial, anterolateral, and posterior. So we are at the medial segment, and then we have these three segments coming out of it. This is 8, 9, and 10. And when you see this segment 9, it divides into a keyhole pattern, and then subsequently segment 9 divides into side by side or a vertical branching. And one of the segments, especially the subsegments labeled as RB9A2, is actually reaching to the lesion. So this patient comes for bronchoscopic intervention after the 3 weeks of his CT scan. Usually we do at least an X-ray before your bronchoscopic intervention, and it was fairly static. So when we went ahead with bronchoscopy, and as I can show you this, there's a lesion reaching seen directly into segment 9. This is the medial one. We have 8, 9, and segment 10. We are going into segment 9. A path was directly leading into the lesion. It was rapidly increasing in size. And we did multiple biopsies at this location, which turns out to be a hepatocellular carcinoma. The microbiological investigations were negative. So in a treated case of HCC, the lung lesion was a metastatic HCC. This patient was further treated with chemotherapy. Now I'll show you a case of complex and multiple lesions, how we approach them for the diagnosis and treatment. A 64-year gentleman, no comorbidities, been a smoker, diagnosed in 2019 with CA hypopharynx, a squamous cell carcinoma, initially treated with neoadjuvant chemotherapy followed by a chemo and a radiation therapy combination. Year down, he develops a nodal recurrence in the neck and undergoes the salvage neck dissection. And this was his initial scan, including the PET scan. You can see right lobe of some subtle ground glass opacity. No major avidity called at inflammatory or infective. Because it's a head and neck cancer, you tend to have some microaspirations or aspirations. There was no respiratory symptoms. This patient was treated with antibiotics and was followed up with the scan. But because it was a time of COVID pandemic and a lot of healthcare got hampered, patients got delayed access to the healthcare. He used to stay somewhere in northern India. So he came in April 2022 with dry cough for 3 months, and his CT scan showed right upper lobe lesion. Now, this is a solid looking lesion with some internal breakdown or a bronchus leading to it. We have spiculated margin, and the right lower lobe ground glass opacity had some subtle solid opacity within. So this was April 2022, and earlier when you compared to this GGO, this has some solid component. Now we are dealing with a multiple lung lesions. One of them is larger in size. This patient has been a smoker, has a head and neck cancer, which is recurrent, is elderly, had multiple lung lesions. So we target the largest upper lobe lesions, which was most suspicious. And let me show you these lesions in detail. This was the upper lobe lesion, which has a bronchus leading to it. And we have lower lobe ground glass with some subtle solid appearing lesion, no major mediastinal lymph nodes. So we planned a careful bronchial branch tracing, and let me just show you that. So this is the upper lobe bronchus, that is RB1. Subsequently, when you go down, you can see a posterior segmental bronchus, that is RB2 here. Okay, and careful tracing further leads to anterosegmental bronchus, that is RB3, which further divides into lateral and medial segmental bronchus, that is A and B. And if you carefully see the medial segmental bronchus, it goes further into 2 more branches, which is again medial and lateral. And you can see these 2 horizontal branching subsegments, and then a lateral one is actually leading to the lesion. So this was the location of lesion RB3B1. And careful bronchoscopy was done with radial EBUS. You can see RB1, 2, and 3. In 3, we have these 2 subsegments. And one of the B subsegment, we are going with your radial EBUS with a guide sheath. And we could actually reach to the lesion. Lesion was quite peripheral. And once we went into the core of a central part of lesion, it appeared to be eccentric. Now, in this situation, we went ahead with the therapeutic scope. So we have put a guide sheath. You can see an eccentric located lesion. So we have put a guide sheath. You can see the metal mark of the guide sheath just proximal to the lesion. An adequate throw of a forceps was done, and multiple biopsies were taken. It turns out to be a necrotizing granulomatous inflammation. Gene expert was medium detected. Rifampicin resistance was detected on gene expert. The bulk cytology from the upper as well as lower lobe was negative. The 4 weeks culture showed a growth of MTB complex, which has resistance to INH and rifampicin. and rest of drugs were sensitive. This patient was treated with bedaquiline-based treatment in a government TB program and was asked to follow up after 3 months. And this patient follows up, he was following locally in northern India, and then he came after 10 to 11 months. His subsequent scan shows significant resolution in the upper lobe lesion. But look at what has happened to the lower lobe lesion. It has become more solid. The ground glass component has reduced, and there is an increase in the PET avidity. So most of times these cancers are followed with CT scans or a PET CT scans yearly to look for any recurrence. And in our patient, there was significant TB was there. It was resolved very nicely. He was still on the treatment, but lower lobe lesion has increased. So we again went ahead with careful MDT discussion and decided to identify it was in the superior segment of the right lower lobe, went ahead with a radial EBUS with a cryobiopsy and a lavage, and it turns out to be adenocarcinoma with microbiological workup negative for tuberculosis. So this patient further was planned for surgical resection. So we had a case of head and neck cancer, developed tuberculosis on follow-up, complicated by the COVID situation for careful follow-up of these patients. And subsequently, a ground glass lesion evolved into a partly solid and a solid lesion, turns out to be adenocarcinoma of lung. And when you practice at high volume center, you come to multicentric cancers or synchronous or metachronous cancers in a different organ. Other clinical scenario come across is the mediastinal lymph node with peripheral lesion, and it's a case of 43-year female who's been a non-smoker, is newly detected left breast cancer with mediastinal lymph node. Now, breast cancer, they can remove the supraclavicular axillary lymph nodes, but they can't resect the mediastinal lymph nodes. And this patient with the mediastinal lymph node positive becomes non-operable. So we are dealing with a mediastinal lymphadenopathy and a right lower lobe lesion. Let me just show you that lesion on the axial scan. We have right lower lobe segment 10 lesion here. So again, radial EBUS plus EBUS was planned. First, we usually do EBUS followed by radial EBUS. So again, we flip the image to identify the lower lobe and trace these branches carefully. So you see this is segment 7. The superior, you have a superior segment coming out here. This is the medial basal segment, and then we have basal segmental bronchus coming here. Subsequently, carefully, you have to see it is a high resolution scan. It divides into, not in the PET scan, please use a high resolution scan, but PET scan can give you a reasonable idea if it is performed in proper phase, in a deep inspiration. So we have segment 8 and then a basal segmental bronchus. The basal segmental bronchus further divides into 2. I don't know whether it is appearing clearly on the scan or not, but this is the segment 9 and 10. And when you go down further, the 10 further divides and leads to the lesion. So here the segment 10 had both medial and lateral segments, which was reaching carefully into the lesion. So this is a bronchoscopic view, right upper lobe, right lower lobe, where we have the right middle lobe bronchus, RB6, RB7 medial segment, and then lower lobe basal segmental bronchus. When you go further into the basal segmental bronchus, you'll be able to identify segment 8, 9 and 10 were arising together. And in segment 8, there was nothing endobronchial. Carefully inspect the segment 9 as well. And sometimes you have to put your radial probes also in a adjacent segment to elicit the region. And then in segment 10, we had 2 more subsegments. Sometimes the nomenclature doesn't matter. You need to understand the path where exactly you need to reach. And we were actually reaching to the lesion. It showed some external compression as well as endobronchial component and some small openings. So this is how you depict your bronchial branch tracing to the bronchoscopic image. We have RB7 superior segmental bronchus and the basal segmental bronchus, which divides into 8, 9, and 10. And here is 9 and 10 corresponding to the bronchial image, and the segment 10 was actually reaching to the lesion. So radial EBUS was performed. We went and we could identify the lesion very well. A heterogeneous density lesion was located. And then under fluoroscopy guidance, we did multiple biopsies with a forceps, and we have done lavage. And this turns out to be a metastatic adenocarcinoma in right lower lobe lesion. Even the EBUS image, EBUS biopsy had shown metastatic lymph node. So EBUS was done, but lower lobe lesion was also simultaneously tackled, because we have seen in earlier situation whether the node, even on radiology, the lesion appeared to be malignant in the right upper lobe in earlier case. It turned out to be TB. So in this situation, we targeted the parenchymal lesion as well. Our next case is a most peripheral located lesion, and where we used a virtual bronchoscopy navigation, a synapse system. So case of a periampullary carcinoma treated with surgery. A year down, he develops disseminated tuberculosis, which was a pan-sensitive strain, and we treated with 1 year of NTTB treatment. And 2024, he presented to us with again symptoms of cough, fever, and weight loss. This is his CT scan. You can see left lower lobe. We have most peripheral located lesion in the basal segmental bronchus lateral as well as the posterior basal segment. One of the lesion was subpleural located. So lower lobe lesions most of times complicate the bronchoscopy sampling because of the diaphragmatic movement as well as the atelectasis which develops when they are under anesthesia. So careful planning was done with navigation bronchoscopy, a synapse system. And the synapse has given, usually we need a high resolution scan uploaded to the system. There is a planning involved. It takes around 5 to 10 minutes to plan. And it took us to the most basal segmental bronchus, segment 10 and 9. Both were reaching two different lesions. So this is the basal segmental bronchus. On a posterior basal, we went ahead with a radial EBUS. And if I can show you, it was most peripheral located lesion, but it is sometimes difficult to differentiate between atelectasis and the lesion. You can see the lesion was located just subpleural peripheral. We have screened multiple segments, and one of the segments gave us the concentric image. This is the forceps reaching to that area. We have done a thorough dedicated lavage, segmental lavage, as guided by navigation bronchoscopy in this segment, and we did multiple biopsies. Though it is a 2D image and it's difficult to identify the lesion on fluoroscopy, sometimes you can do a right axis and a left axis orientation on the fluoro to see whether you are actually inside the lesion. It is difficult when you are dealing with the basal segmental lesions. Now, this biopsy turns out to be an organizing pneumonia with few fungal filaments. Aspergillus was also seen, and this patient was treated with voriconazole. So quite a few cases, especially from northern India, we get where we have opportunistic infections or even Aspergillus fumigatus, which is commonly seen in those geographic areas. My next case is we have seen all centric lesions. Now we are dealing with the eccentric lesion. This case credit is of my colleague, Dr. Ganapriya, where we did cryobiopsy was used. A 46-year female, no comorbidity. Similar scenario of a left breast cancer treated with surgery. 2 years down, the screening, the follow-up scan shows right upper lobe well-defined lesion. No mediastinal lymph nodes. So a careful planning was done, and segment RB2A was identified. This was eccentrically located lesion, you can see. So decision was made to do a cryobiopsy because a forceps may not be inside the lesion and you may not get adequate tissue. So the cryoprobe goes into a desired segment. And then under fluoroscopy guidance, you have to identify whether you're reaching to the segment of interest. And then the cryoprobe is actuated for 4 to 5 seconds. And then in toto with the scope, you have to pull the probe, keeping the cryo activated, and we have to take multiple samples. We take around 5 to 6 pieces. 5 pieces were done in this case, and a good amount of tissue was obtained with, and that's the beauty of cryo. You can get more tissue with cryo. And these are the pieces obtained, and this turns out to be a case of metastatic adenocarcinoma. So we have seen a wide array of screen detected, follow-up scans showing multiple lung lesions being sampled, turned out to be TB, fungus, or malignancy. But do all the nodules, all the lesions what you look at on the CT scan require follow-up? And there's the importance of your MDT comes in. And there are couple of cases I would like to show you regarding this. Is case of elderly male with diabetic hypertension who has urothelial cancer, and 2 years down, a follow-up scan was done. He had the symptoms of cough and weight loss. And if I can show you, there are some nodules located in the fissure. You can see on the left side as well as on the right side, we have subtle nodules located near the fissure. This patient had multiple mediastinal lymph nodes, few were calcific, but because he had respiratory symptoms, he was advised for sampling of these nodes. And the EBUS TBNA showed 4R and 7 stations showed reactive. The infection workup was negative, and this patient was kept under radiological follow-up. The nodes didn't increase in size, no architectural change. And if you can see, these nodules, peripheral nodules were fairly static. So peripheral nodules is a unique situation, and MDT can help you to identify these nodules, which nodules to be biopsied or not, and they can fairly kept under radiological follow-up. The last case is a case of 43 years male smoker presented with hoarseness of voice and dry cough. It's oncological center. We get a lot of references considering the lesions being malignant. And the vocal cord showed the right vocal cord had polypoidal lesion. The biopsy was done, which was hyalinized nodule, no malignancy. But his CT scan, if you can see in the actual image, showed a lesion located in the left lower lobe around 2.4 centimeters size. And let me show you this lesion in actual section. We have a lesion coming in the basal segmental bronchus near the aorta, near the paravertebral location. So this lesion should be studied in all mediastinal, plane, contrast, as well as axial images, and even the sagittal and coronal images, as I have showed in the beginning. So in this patient, we had a lesion para-aortic location. The lesion had a very unique heterogeneous density, some fluid density as well as solid component and contrast enhancement with blood vessel. So we had our MDT, our radiologist wisely pointed out in a sagittal section, you can see the lesion being para-aortic location. I'll give you a few seconds. What is your diagnosis here? So this was a lesion referred for further evaluation, and a careful planning of a arterial and venous contrast phase showed us there are a lot of blood vessels inside the lesion, and one of the vessel was arising from the aorta. This is a classic case of a intralobar sequestration of a lung. So, the point of showing you this case that not all nodules require biopsy. IMDT adds to the diagnosis. Different experts contribute differently. Sometimes you may miss something which might be pointed out by your colleague. And if you have a lesion located in vicinity of a blood vessel, then it's preferable, or if you have a blood vessel leading to the lesion, then it's preferable to use a contrast CT scan, and you can consider an arterial as well as a venous phase contrast before putting a needle inside. So for PPL, usually what we do, look at the pretest probability. Are we dealing with infection or malignancy? And in Indian situation, it's very difficult to differentiate. But if you can rule out infection clinically with a lab or a sputum evaluation, that's easy to access in most of the centers. However, don't stop there. Don't label the patient as infective. Don't try only empiric antibiotic or empiric anti-TB treatment, and prefer to have a scan in the patient. If possible, do a contrast CT scan with or without PET scan. But now remember that interpretation of PET should be done cautiously, because not all light stuff on the PET is malignant. And you can consider, if you have MDT, you have virtual MDT, or if you decide for a tissue diagnosis, then look at the simple protocol we used and described earlier. If the lesion is subpleural, you can have a CT-guided biopsy, most commonly done. If you have a bronchus sign positive, if you have concomitant mediastinal lymph node, different nodules, infective etiology, you can consider radial EBUS and EBUS together. If the lung parenchyma has a lot of emphysema, cyst or bullae, in that situation, prefer a bronchoscopic route because the risk of pneumothorax with CT guided is high. And whenever there is a suspicion of infection, always ensure you send microbiological samples. Do a lavage. Usually you do brush followed by biopsy. If you are using a cryo, use the multiple cryo biopsies, and then we use the lavage later on. Now, remember that for the microbiological investigation, you should send a lavage and a tissue obtained by the forceps rather than a cryo. Cryo may give a gene expert yield positive, but it has some inhibitory effect on culture growth, and our microbiologist prefers to have a forceps or a lavage sample rather than a cryo sample for AFB cultures. So to summarize, every nodule, every lesion, always discuss in an MDT if possible, and you can do an MDT and put a needle later once everybody is convinced for the diagnosis. If CT guided feasible, send for CT guided. If bronchoscopy, choose a bronchoscopy, and if not, or if everything is negative, you can consider surgical biopsy as a last resort. See the vessel, use the contrast to identify the lesions or vicinity of the lesion into the near the blood vessels. You have to know your anatomy well. Bronchial branch tracing is a savior. It's an essential skill. Initially, it is time consuming, but as you do more cases, it becomes easier. And the navigation tools are definitely complementary to your bronchial branch tracing, improving your accuracy, especially when you deal with peripheral lesion. If the lesion is eccentric, think about a cryobiopsy. Remember, the CT-guided biopsy and bronchoscopic biopsies are complementary to each other. And in endemic situation, do not forget to send sample for microbiological investigation. So at the end, I thank, this is our thoracic oncology disease management group, relentlessly working to serve the cancer patients across Indian subcontinent. this kind of work is not feasible without a great team support. I thank my Department of Pulmonary Medicine as well as our thoracic DMG for their constant support. And thank you, Dr. Vishweshwaran, for giving me this opportunity to share our work on your platform. Thank you.
Thank you, Dr. Pawan, for giving us an excellent overview of how we really practice the diagnostic aspects of interventional pulmonology in an Indian scenario. We can, even without the help of a robo, it is possible to get diagnosis, and definitely a robo will be an add-on. And with the advancements that is coming in the therapeutic aspects of peripheral pulmonary nodule, possibly the utility of the cone beam CT and the robo will be much higher in the coming days, and it is worthwhile to have insights on the utility of the robo as well as the cone beam CT. So with this, I move to the last part of the talk for the day. So here it will be an interesting case of the month. So this last month we saw about how we really go about doing a rigid bronchoscopic debulking of a central airway tumor. This time I thought that I'll present our experience on management of bronchopleural fistula with the help of the bronchoscopic techniques. So I'm just sharing my presentation here. So I'll just take you through the cases to make you understand how we really do the bronchoscopic management of a bronchopleural fistula. So this was a patient who was referred to us with a persistent air leak. And as you can see from the radiological images here, the patient is having a community-acquired pneumonia. Along with that, the patient was also having a bronchopleural fistula with a persistent air leak. And CT plays a vital role in understanding the severity of the airway leak, and it also helps us to uh, choose the site where we need to place these spigots or glue to close this bronchopleural fistula. For example, if you get this section of the CT, you can clearly see that there is a communicating bronchus which is directly leading on to the pleura, and this is responsible for the bronchopleural fistula. So as a part of routine for most of the cases of a bronchopleural fistula, we do a CT scan. We try to trace the bronchus that is leading into the fistula site so that it decreases our time in localizing the fistula. And then pretty much we are successful in doing this bronchoscopic closure of the BPF. Now I'll take you through this video and slowly we'll try to understand how we really do it. So the first and the foremost thing what we do is we get a good CT scan and then we take a video recording of the BPF before we go about doing the closure. So now you can see that there is a continuous air leak which can be seen in the water seal. There should be a dedicated person who is observing this while we as an interventional pulmonologist are doing the procedure, because the moment you occlude the segment that is leading into the leak, you can see that there will be a gross reduction in this air leak. For example, now you can see that there is a continuous air leak in the water seal. Once I know that the patient is having a continuous air leak, now we induce this patient. Generally, we do it under general anesthesia because while doing the glue, if a patient coughs in a conscious sedation, then it can occlude the tip of your bronchoscope and can damage your bronchoscope. Once it is done, then what we are doing is called as a serial balloon occlusion technique. Essentially, what we do is we go inside the airway and then we pass the Fogarty balloon and then we try to occlude from the proximal bronchus to the distal subsegmental bronchus to identify the particular spot from where the leak is occurring. Let's say that I am occluding the right upper lobe, and if the leak stops in the water seal, then I know that probably the leak is coming from one of the subsegments or from multiple segments of the right upper lobe. So this can be effectively identified with the help of this sequential balloon occlusion. So now you can see that I am occluding the airway with the help of the Fogarty balloon. And in this case, now you can see that I am passing through each and every subsegment to identify the particular subsegment from the leak is occurring. And now you can see that once I close the lingular lobe of the bronchus with the help of a Fogarty balloon, there is a gross reduction in the air leak in the water seal. So in this way, we can particularly identify the subsegment as well as the segmental bronchus from which the leak is occurring. Once it is done, now we need to close the leak. So what essentially we do is that it is a mechanical closure of the BPF with the help of something, a silicon plug, which we refer to as a Watanabe-based spigot. So this Watanabe spigot has got some uh, projections at its surface. So that helps in anchoring of the spigot onto the bronchus where it has to be placed. And we hold it with the help of a rat tooth forceps. It can be done even with a laryngeal mask airway, as we are doing it in this case, but sometimes we put a rigid bronchoscopy, so it facilitates the easy placement of this Watanabe spigots. And once I know that particular segment from where the leak is occurring, now I am passing the Watanabe spigot into that subsegment and I upload it. Again, once it is placed, it is prudent to see if the leak has completely stopped or not. And if the leak has not completely stopped, then possibly there is another subsegment which is also contributing to the leak. And you may have to place multiple spigots to close this leak. And as you can see from the video here, once I have placed a spigot into the lingular bronchus, now we see into the water seal and we know from the water seal that the air leak has completely stopped. And once we know that the air leak has completely stopped, now we are anchoring this spigot uh, uh, firmly inside the affected bronchus. There are multiple sizes which are available. The generally we use what we use are the 5 mm, 6 mm, and the 7 mm, depending upon the size of the bronchus which is leading into the fistula. And then we want to anchor this spigot. So what we are doing is we are putting the cyanoacrylate glue. This is the most crucial step of BPF closure, because if you are not careful enough, what can essentially happen is, let's say that you are doing this patient in a conscious sedation, the patient can cough and this glue can come and get attached to the tip of your bronchoscope and can actually damage your bronchoscope permanently. So what we are doing essentially in this case is we are passing an epidural catheter, and through the epidural catheter, we are instilling the glue surrounding the spigot. This is generally done because if a glue is not placed, possibly after you take this patient out of general anesthesia, if he coughs, this spigot can get displaced. So this glue helps in anchoring the spigot in place, and slowly the leak decreases, and eventually over a period of time, the leak completely stops and you will be successful in removing this patient from the intercostal drainage tube. So now you can see post-procedure, there is a complete closure of the BPF. And the second day, the patient ICD was removed and you can see a complete expansion of the lung. So in this case, we were very successful in identifying the actual site of the BPF only with the help of a Fogarty balloon occlusion technique. But however, it may not be the case in all patients. So here in this case, this is yet another patient where you can see that we are trying to identify the site of the leak with the help of a Fogarty balloon, but we were not able to identify it accurately. So in this case, what we do is the methylene blue installation. Initially, you can see that there is a lot of a BPF which is coming, which is present in the water seal. And once we know that the BPF is there, now we are passing this Fogarty balloon to identify the particular site of the leak. We placed it at the superior segment of left lower lobe, but we were a little doubtful whether this is the only site of leak. So what we do in this case is called as a intrapleural instillation of a methylene blue. So we put the patient with the affected side upwards, and then we instill the methylene blue, and simultaneously through the bronchoscopy, we visualize from where this methylene blue is leaking. Once we localize the particular subsegment from where the methylene blue is coming, we know that there is a direct communication between the pleura as well as this affected subsegment. Then we take the Fogarty, then we take this Watanabe spigot with the help of the rat tooth forceps. In this case, we are doing it with the help of a rigid bronchoscope. And once we go inside, we choose that particular subsegment from where the leak is occurring. And then we place this spigot in place. And then what we are doing is we are going to instill the glue again. And once the glue is installed with the help of an epidural catheter through the flexible bronchoscope, now you can see that the spigot is anchored in place and the BPF has stopped. And then later you can see that the lung has completely expanded and we were able to successfully remove the ICD. So in cases where you find that you are not able to surgically manage this BPF, or if there is a post-surgical bronchopleural fistula, or if the pleural fistula is of low grade, then your bronchoscopic management of a bronchopleural fistula comes handy, and you can use a spigot, you can use a glue. And in forthcoming videos, I'll also show you that we use certain other techniques like placement of a even a silicone stent, or sometimes we can even place an Amplatzus device to close this bronchopleural fistula. So I think this video was informative for you in understanding the technical aspects of the bronchoscopic management of a BPF. And I'd like to end the presentation here. And thank you one and all again for joining this episode of IP Mentor web series. And we'll keep having this web meet every Sunday, every second Sunday of the month. And if you have any queries, you can feel free to drop us a mail or messages, and we'll be more than happy to reply. Again, I'd like to thank both the speakers for their excellent inputs on how we manage peripheral pulmonary nodule in 2026, both in the western part of the world as well as in the Indian subcontinent. And take care, and meet you once again for yet another interesting session on advanced interventional pulmonology. Thank you.